Our next speaker, it gives me absolutely great pleasure to welcome Sir Julian Hartley. Sir Julian joined Leeds Teaching Hospital and led a transformation in cultural change, something known as, and still spoken as today, as the Leeds Way. And it's quite scary, that 2014 piece that David put up there, because it was very shortly after that that we got to meet Sir Julian and his team at Leeds, who were very early adopters and saw the value of GS1 standards and scan for safety. Absolutely phenomenal. And that legacy has continued past Julian's time. And Steve Bush, who many of you know and will be speaking later, is now the current holder of that particular torch. Whilst at Leeds, Sir Julian was seconded, I think is the polite term, to go and help the centre look at the workforce plan. And he did that and ran back to Leeds as quickly as possible. The centre then called him back to be Chief Executive of NHS Providers, which he left a few months ago, to take on a new role as Chief Executive of the Care Quality Commission. It is with great pleasure that we welcome Sir Julian Hartley to the stage.
Well, good morning, everyone. And Glenn, thanks for that very generous introduction. It's great to be here with you. And I thought what I'd perhaps do is just say, first of all, a little bit about where we are currently with CQC. Many of you will know that the Care Quality Commission has been through a pretty turbulent period of late. I think perhaps the low water mark being, you'll probably recall, end of last summer, penny dash review into its operational effectiveness, and Secretary of State describing CQC as not fit for purpose. Major issues and challenges for the organisation related to its implementation of a new regulatory platform, a major IT transformation that went badly wrong, an attempt to establish a single assessment framework for all sectors, and a move away from specialist expertise to a more generalist approach, all of which I think combined to create a major challenge for the organisation and a huge drop-off in the level of performance. Now, I joined CQC in December of last year, and it was clear that we have got a lot of work to do to ensure that we restore our effectiveness, our credibility as a regulator, but we can't do that on our own. We need your help in terms of making sure that we build an organisation, and I've always believed that really good regulation acts as a spur to improvement. Yes, it's vital for us to protect people that use services. And yes, we do have that enforcement role. But in the main, we should be about highlighting what's working, where good practice exists, how we can really support improvement at a time of great change and challenge for the health and care sector. And certainly starting in this job, I've learned a huge amount about the importance of home care, nursing home care, the importance of the independent sector, as well as obviously the vital role that I spent my career in the National Health Service. So there's quite a big set of challenges ahead of us, and just to give you a little bit of a sense of the journey that we are on, I think it's fair to say that in terms of that point about sector expertise, you know, the importance of, and I would argue, as I'm sure many of you in the room will probably be on the end of a CQC inspection, certainly know that I've been through a few, and I think you always look for that sense that you've got an inspection team that understand your business, they understand your sector, that you can speak to them as peers, and certainly that's something we're prioritising in terms of the appointment of 4 chief inspectors. And for the first time, we're appointing a chief inspector of mental health because given the scale of the challenges we're facing in mental health, I'm sure you'd agree, it's vital that we've got that at the same level as our other 3 chief inspectors of primary and community care, adult social care, and hospitals. So I was delighted that we were able to appoint Dr. Aaron Chopra to the role of Chief Inspector Mental Health. Aaron comes to us from the Mental Wellbeing Commission in Scotland, and he'll be starting with us in the middle of May. So that's exciting, and we're hoping to make appointments to the others fairly soon. Also, we're having to look at how we mend that regulatory platform. I commissioned an independent review of that, which highlighted the scale of the investment and the minimal benefits accrued so far. So there's a big challenge for us to maximize the use of technology. And I think I heard a scary statistic from someone at a conference recently about 70% of major IT transformations fail. You've got to work hard in terms of making sure they succeed. And I would argue strongly that you do that through not just seeing it as an IT project, but seeing it as part of a major cultural approach where you engage everyone in the overall benefit to patients, to people that use services. And the training and the engagement of frontline teams and the way that you govern and manage any major project is absolutely central to its success, which is why, and Glenn, you mentioned it, thank you, which is why I was so delighted to be able to support the great work that we did on Scan for Safety in Leeds, and it's great that both Steve Bush and Mark Songhurst are here, and you'll hear from them later. But my reflections on that, as an aside, would be that work wasn't in isolation. It was connected to our approach at the time, which was about that cultural engagement, as well as having a clear, continuous quality improvement method. And I think every organisation in health and care really needs to be clear about what its improvement method is. We were fortunate that we got to partner with Virginia Mason in Seattle, a sort of globally acknowledged leader in the application of lean methods in healthcare. And what Scan for Safety did beautifully was fit that mold of the mantra of focusing on what does and doesn't add value to patients. And if it doesn't add value to patients, then question why are we doing it? And also just the approach culturally to go see, ask why, show respect. And the way in which the team implementing Scan for Safety went about their business was absolutely based on those key principles. And the importance of engaging frontline staff in this work is paramount. And the number of major transformations that fail because of the lack of that frontline engagement is significant. So coming into this job in terms of Care Quality Commission, I draw inspiration from my time, a decade spent working in Leeds teaching hospitals, as well as seeing the great work going on across a range of NHS providers. And it's great, Terence is here, and Terence is current chair of NHS providers. Trusts are doing some phenomenal work right now in terms of this agenda, but these are tough times as far as the financial pressures and as far as maintaining and supporting high quality care. So just a little word about what we do. So you can see clearly our main objective as Care Quality Commission is all about protecting, promoting health, safety and welfare of people who use health and social care services. We are, there's often a lot of critique about the idea of ratings, but it's interesting since coming into this job, a lot of the public do look for that. They do look for that sort of sense of assurance, particularly in the care home sector, in terms of decisions about where where, in terms of their nearest and dearest that might need support in a care home. And our job in terms of getting out there and doing inspections is crucial to give that assurance, but also to hold the mirror up in terms of the standards of care currently. A fundamental part of our role, though, is to encourage and support providers to improve and provide safe care. Certainly my experience in trusts I've worked in the past of CQC is it works best when there is that sense of highlighting in a very clear and honest way where we're falling short, but also pointing the way to improvement so that the reports are more formative than just a summative judgment. And I think that's important in terms of how we go about our business. Our regulations are clear and set up in 2008. The regulations set out what the minimum standards expected. But interestingly, it is safety where we find the poorest area of performance in our inspections, and that remains a key concern. Safety is central, obviously, to the work of the health and care sector. And in the context of this discussion, the application of technology to improve and support safe care, it's vital that we get that right. So the landscape is changing, isn't it? And I guess the discussions that you've been having at this conference have highlighted a lot of that. That will impact on us as the regulator. So innovation, technology, and artificial intelligence, the three shifts that I'm sure have been mentioned a number of times, those present real opportunity, but also some questions and concerns in terms of technology. We need to ensure regulation supports and enables innovation. It's important, some critics of regulation say, oh, well, it stifles innovation. It doesn't, it's all about minimizing risk. But I think it's important that we're able to take a view as a regulator that sort of empowers boards of organizations and also puts a premium on that sense of ownership of their own risks and making sure that there's a triangulation of quality safety at the board tables from ward to board in terms of making sure that we're not trying to do that job for them. So vital to make sure that we're there to promote and support that innovation. And frankly, innovation supports patient safety. And we've seen that through the work, and we certainly saw it in Leeds through the work on Scan for Safety, where the benefits of that approach in terms of being able to track the whole sort of pathway and the journey of every single device, and also the relationship at a time of enormous financial pressure between high quality care and waste reduction. And a big thing we learned was how to minimize waste. And waste is everywhere, isn't it, in any healthcare setting. And the best people to spot and identify are those at the front line. So the way that lots of our teams would undertake waste walks where they'd go and spot, you know, unnecessary movement or the time it takes to find a certain piece of equipment. And when you aggregate all of that time lost, all of that duplication of effort, all of that walking around to find equipment, you know, the value of that time and the value of that is enormous. And we tracked all of that, and our finance director worked out, I think, that through the approach of waste reduction allied to quality, we saved just in 1 year around £16 million allied to specific waste reduction activities. So this, I think, is a hugely important agenda in the context of how we move forward to tackle some of the big financial challenges that we're facing. But we also have to balance the approach around technology with a focus on risk, including obviously the use of digital technology, the risks there around errors, misdiagnosis, the risks of new technology exacerbating inequalities. Health inequalities, I think, if you look at the Institute of Healthcare Improvement's now quintuple aim, you'll be familiar perhaps with the triple aim in terms of patient experience and outcomes, population health and efficiency, but added to that, staff experience and health inequalities. And I think health inequalities is one of the challenges of our age in terms of what we're seeing, particularly in some key services like maternity. Safety science and human factors expertise in trusts via the National Patient Safety Syllabus can help ensure innovations are implemented in a safe way. And I think that there's a real premium on clinical leadership right now in terms of senior clinicians in our organisations with that focus on safety, with that engagement of all of their colleagues in this agenda, and there's some good resources out there to support that. So the landscape's changing across health and care. There's lots of work going on to tackle inequalities, but we see trends embedding further. So the quality and safety of maternity is a big concern. Differences in demographic data to try and address inequalities, particularly those experienced by women from Black and ethnic minority groups. And this is a consistent theme in a lot of the work that we've done and the inspections and the feedback that we see. Children and young people's health, particularly in relation to elective weights and being able to access emergency services promptly, and access to children and young people's mental health care is especially concerning. We at NHS providers, I remember saying quite a lot about this issue, particularly in terms of the sort of 40% increase in referrals into child and adolescent mental health services. You know, the scale of the challenge for children's services is huge, and this is a vital kind of time for us to be thinking about how do we improve that. Similarly, care for autistic people and people with a learning disability. This is an area of particular concern and focus. Black men's mental health, where it's very clear from the evidence there's much greater likelihood of being detained, and people with dementia. So those themes and issues are of great importance at the moment. Those are the things that we think we need to see particular focus on. And then, of course, the quality and safety landscape is changing and shifting. So there is a move, and we're waiting for the next iteration of the work that Dr. Penny Dash has done in terms of her review of patient safety landscape. Obviously, big change around NHS England in terms of work there. And increasingly, we're seeing care delivered across organisational boundaries. And I can remember particularly powerful CQC's work with us in Leeds on system-wide view of frailty, looking not only at what we were doing in the hospital, but what was happening in primary care, social care, mental health, voluntary sector. And actually that led to a lot of work on better connectivity, because often it's between the gaps that we see some of the problems. I'm sure many of you either experienced personally or friends and family where different parts of the health and care system aren't sufficiently connected, and there are discontinuities in terms of care and treatment. And the work that we did on that piece of work on frailty really helped support our effectiveness there. So that is it. That is it from me, Glenn, in terms of talking at you. Very happy to take any quick questions. Just to say, do look out for opportunities to get involved in work of CQC. We'll only be a regulator as good as the level of engagement we have from colleagues that we regulate in terms of helping support our work and making sure that we get it right in the new world. Thanks very much.
Thank you, Sir Julian. That's one heck of a to-do list, isn't it? I mean, that's just trying to process each of those as a job on its own. I will go to the audience for questions. I'm sure there'll be some, but the first one you're going to have to cope with, which is for me, because looking at all that, and I know you're used to massive organisations and getting things done, but let's say it's 2028. Which is the one thing that you would say that you would make you the most happiest to have achieved?
That's a really tough question, Glenn. Yeah. I think seeing measurable progress on some of those fundamental inequalities that we're seeing at the moment across the range of those services I highlighted, and a sense that we as the regulator are really supporting and adding value, and that by 2028 we can point to many examples of change and improvement as a consequence of positive regulatory work.
No, thank you. And I think all of us, including those of us that don't work within the health services, can relate to all the things you've done there. So the first key to success is acknowledge the problem, isn't it? And I think they've done that brilliantly today. Thank you. Questions then, please.
Ali Robson from EY Health Partner. The question really I had, Julian, was you talked about the role of technology and how that is and the risks of it. And I was just interested in your views between how we use technology sometimes to make the processes that have an inbuilt level of inequality more efficient, rather than going back and doing the transformation part to say, well, now we have this technology, how do we resolve a problem and do it differently? Because to me, I feel that it's a very easy thing we do to get an efficiency, but we don't then actually think about it. Have we actually resolved a problem?
Exactly. I think that's a really, really good point. I think that is true. So I think what you have to do is go back and examine first principles. Good example of that was across West Yorkshire, we set up a provider collaborative, 6 trusts working closely together. One of the things we did early on, inspired by a lot of the work that was happening at Calderdale and Huddersfield, was we all committed to analyse our waiting lists by index of multiple deprivation and ethnicity. Now, you would think, wouldn't you, that waiting lists are a kind of rational process that is sort of objective and, extraordinary looking at, when you do that analysis, some of the gaps in terms of access to services based on deprivation, ethnicity, and so on. So having exposed that, then the question was, how are we going to address this? Now, I don't think we'd have addressed it in the way we did had we not taken those steps back. If we'd just gone for the classic, let's improve the processes with the existing list, we'd have just kind of embedded and continued with the inequalities that existed. So I do think in any of those sort of programs around improvement and efficiency and application of technology, you've got to sort of really get back to first principles around where you are and understand where you are from an inequalities perspective from the start.
Thank you. Thank you, Sir Julian. Thank you very much, and good luck.
Thank you.